Thank you. So we're going to have questions now from the members, 5 minutes. In some cases more, I think, if the members passed on their opening. I wanted to start with Mr. Elmendorf because of the issue of primary care. Many experts, such as Dartmouth researchers, maintain that a lack of access to high-quality primary care contributes to inefficient care and geographic variations around the nation. And they say that if we invest more in primary care to improve quality and lower costs, that would be one of the main efficiencies that we could achieve. And I have to say that, when you listen to President Obama at the summit last Thursday, he stressed, this whole idea of health inflation, and that somehow we have to curb the growth in costs. I think Karen Ignani from the health insurance trade group or whatever, actually at my breakout session talked about, curbing the growth or the inflation, if you will. And I have to give you, personal experience. I mean, there's a couple of my staff people in my office in New Jersey have, Cadillac health insurance, Blue Cross, whatever, and have had a problem getting a primary care doctor. On 2 occasions, because they couldn't get a primary care doctor, ended up going to an emergency room for, something that really wasn't necessary to go to the emergency room. And, I keep saying, we keep talking about people who have no insurance that go to the emergency room. Well, what about a congressional staff person who has insurance and can't get a primary care doctor and goes to an emergency room? So my question is, with regard to primary care, and particularly within the Medicare program, I mean, you mentioned this patient-centered medical home as an option, but talk a little bit more about what you see in terms of enhancing primary care and how important that is to the overall system in terms of cost efficiencies and trying to make a better quality system.
Mr. Chairman, many analysts have worried for some time that our system does not reward primary care physicians the same way that it rewards physicians in specialties. And if you look across the country and compare medical centers that are seem to be delivering very efficient medical care in the sense of low cost, but medical care of high quality, those medical centers tend to have higher relative numbers of primary care physicians to specialists. And I think that sort of evidence is the basis of some of MedPAC's recommendations in this area. The options that CBO looks at, we've looked at a number of them regarding ways to empower or reward primary care physicians. One is a proposal for establishing medical homes in which all Medicare recipients are assigned to primary care physicians, and those physicians then oversee the way in which those patients receive care from other providers. The crucial issue I think many analysts would agree that sort of focus on primary care physicians would lead to greater coordination of care, fewer duplicative tests, and better health. Whether it leads to cost reductions depends, in our judgment, crucially on the incentives that those primary care physicians receive. So one approach to this is to provide those incentives to primary care physicians by rewarding them for reductions in spending while maintaining high quality. And the effectiveness of those sorts of provisions, so we look at some other provisions, there are other ways, in addition to medical homes, in which primary care physicians can be empowered to make decisions and to coordinate care. But again, it's crucial that if one wants to reduce federal outlays, that they have incentives focused on not just recommending a whole range of additional services that aren't necessary.
Okay. I want to get a second question, but I appreciate that. Mr. Elmendorf, I want to ask Mr. Hackbarth this. Mr. Elmendorf talked about how, you might limit the pace of new procedures, not through rationing, but through, some other means. The president, I commend him. He's been so honest about everything in terms of budgeting. He came up with this $600 billion reserve fund. He said, look, that's only going to pay for half the cost of covering everyone. he even, within that, he said, you know, half of it can be done through cost efficiencies. The other half, you're going to need a new source of funding. You know, all these things are very controversial, but he doesn't hesitate to bring them up, to his credit. But, you know, when you talk about these cost efficiencies, which is MedPAC is, you know, really the key, you know, we get, you know, as you know, you came out with your report, I guess, a week or so ago. And I mean, every time it comes out, the phone rings endlessly in my office because, you know, they see you as like the ultimate bad guys that want to cut back on all the providers and on the imaging and everything else. So, you know, the question is, I mean, how realistic is this? I mean, you know, can we really pay for all these things through cost efficiencies? I mean, are we really going to be able to pay for a quarter of the cost of expanded coverage through these cost efficiencies? Can we pay for even more than that because the President's reserve is only half? Can we, I mean, can you move towards what Mr. Elmendorf said and, you know, actually limit new procedures without having an uproar and without, you know, I mean, I'm not asking you to, I know you're not a politician, but I just wanted you to comment on that if you could. It's endless, obviously, but.
Yeah. Well, let me break it into two parts. First, addressing the issue of new technology, how it's introduced to the system, how it diffuses. In terms of slowing the rate of increase in long-term healthcare costs, that's going to be a principal focus of our efforts. And that's why we strongly supported the idea of a large-scale public investment in comparative effectiveness information. We don't think that that necessarily means that you have to have a single entity making rationing decisions. Indeed, what we've advocated is creating more information so that individual physicians and their patients, private health plans, public health plans, and others can more thoroughly evaluate the choices that need to be made. And we've advocated that the choices continue to be made on a decentralized basis, not in one federal bureaucracy. But we can't make sufficient progress on this technology issue without far better information than we have had in the past. The private market has not and will not produce that information, so public investment is very welcome in that. Having set aside the technology issue for a second, there are very large inefficiencies in the delivery of care, many of them, most of them, rooted in how we pay for care. Realistically, though, as you say, Mr. Chairman, when you change those payment systems, you are doing two things. One, you're redistributing income across different types of providers, sometimes geographically. In addition to that, you're bumping up against really entrenched ways of behaving, you know, cultures that exist within these organizations. And we need to be realistic about how quickly those things will change. They will not change overnight. But to me, what that does is emphasize how important it is we start today and not delay these things further and further into the future. The decisions will be controversial. You're going to need to make those decisions. We'll provide you the best information and analysis we can to support you in that effort.
Thank you. Mr. Deal.
Thank you. As I listen to opening statements in your testimony, two words come to mind, and I want to focus on those two words. Much of what you've just responded to in the chairman's questions, you will respond, I'm sure, the same to mine, but maybe you want to elaborate further. The two words are cost and results. Now, they're not always equated with each other. In fact, we know the statistics. First of all, cost. And I think we all recognize that much of the escalation in cost has been related to new procedures, new treatments, new pharmaceuticals. And Mr. Elmendorf, a partial quote from your testimony about 2 weeks ago to the Senate Finance Committee, you said reducing or slowing spending over the long term would probably require decreasing the pace of adopting new treatments and procedures or limiting the breadth of their application. Now, I've got two questions. My first question is, are there ways to encourage doctors and patients to take into account the cost when making a treatment decision without requiring third parties such as such as the insurance company or other people, including Congress, to make those decisions for them. So that's the question on cost. The second question relates to results. Now, comparative effectiveness is a term that has sent shockwaves through the medical delivery community, as you're aware. Now, when I think of cost comparative effectiveness, I think it can be defined as either the mode of treatment which is generally most effective, which is, I think, the equivalent of a protocol or best practices. But it can also be interpreted as a limitation of treatment, which is where the scary part of rationing comes in. And in that regard, my second question is, what steps can we take to ensure competitive effectiveness research helps improve patient and provider decision-making while avoiding the blunt, centralized access restrictions? My two questions.
So on your first question, Congressman, there are several steps that could be taken to increase incentives for providers and patients to focus on value, on getting results, not just on spending money. One is, mentioned in my testimony, is changing the tax exclusion for health insurance so as not to be open-ended, so that we don't provide essentially a federal subsidy at fairly high rates for people to get ever more expensive policies. Changing that would induce people to be more, and firms to be more cautious in the policies that they bought, to hunt harder for bargains, and that in turn would induce the providers to be more careful in the money that they spend. We could provide incentives for Medicare beneficiaries to choose more carefully additional treatments by increasing the cost-sharing rates. Of course, those policies have consequences as well. More generally, the Medicare program reimburses providers in certain ways, and CBO reviewed a number of options in this volume of ways to encourage providers to economize on spending while maintaining quality, and that includes the way we pay for post-acute care after hospitalization. It includes the way we reimburse doctors, very importantly, because they tend to be paid now on a fee-for-service basis, not on a more bundled basis. On comparative effectiveness, more information is absolutely crucial. There's a very large share of medical care delivered in this country where many analysts think there's very little evidence about what works and what doesn't. And the largest variation in spending across geographic regions is in the aspects of care where there is the least consensus among medical professionals about what is the appropriate treatment. So that providing that information can then provide understanding about what's useful and not, and can try to reduce these disparities. But I think it's absolutely crucial to really get the effectiveness of this sort of research to provide incentives for using it. And that comes up against your concern, which is, well, who's saying that you can't get a certain treatment? And I think the answer here is not to the things people propose don't rule out certain treatments. What it does is to change the incentives so that doing another treatment is not a financial winner. It's a more of a neutral proposition for providers who would then recommend services only if they really are necessary and not otherwise. But the incentives have to go with the information to get the maximum effect.
Yeah, if I could, I'd like to focus on the cost-sharing piece of your question. I addressed the technology piece in my earlier comment. Having patients understand the cost of alternatives can be part of the solution, but it has to be structured very carefully. One of the areas where we think it can be particularly helpful is in Medicare Advantage, where if we give incentives, rewards to patients who enroll in more efficient, high-performance private health plans, that could be a step in the right direction. Our chief concern about Medicare Advantage as currently structured is that we are rewarding Medicare beneficiaries for enrolling in private plans that simply mimic Medicare, except at a much higher cost. So we think with restructuring, Medicare Advantage could be a significant contributor. As far as cost sharing at the point of service is concerned, when care is actually being delivered, Of course, that is could be very problematic for very low-income Medicare beneficiaries who don't have much income and could impede access to care. And there is a body of research showing that, in fact, if you have cost sharing for some types of services, you can end up with worse results and higher costs. An example of that is drugs for diabetics. You don't want to impede access by having them share in the cost. A third point there is that well-structured cost sharing with protections for low-income people that doesn't discourage really needed things like drugs can be okay. But for the really sick patients, they're going to exceed cost-sharing limits. And the real money in our healthcare system is in the care of people that are really complicated and have very high bills. So cost sharing isn't going to solve that problem. We need other tools to address the issue.
Ms. DeGette.
Thank you, Mr. Chairman. I want to explore two sort of issues as we start to think about how we're going to fund health care reform. The first is an issue that I've been thinking about for quite a long time, which is that under the current system, the way the CBO funds health care is just simply by estimating how much it will cost to treat diseases and then paying for that. And a concept I've been working on, I'm calling it the prevention dividend. That's just what I'm calling it. The concept would be that we would try to figure out, and I've actually spent quite a bit of time talking to Peter Orszag about this. We would try to figure out if there are certain treatments or efforts that can prevent disease that we don't necessarily fund now because we can't afford it, and shift the way that we fund health care in this country. And I'll give you one example. When we did the Medicare Part D benefit in this committee a few years ago, I went to then Chairman Barton and I said, Joe, I think we should fund smoking cessation programs for senior citizens in this bill. And he said, I think it's a great idea, Diana, but we can't do it because I've got a $50 billion price tag and I can't go beyond that. So I thought, well, that's swell. We're not going to give them the patch, but we're going to give them treatment for their heart disease, lung cancer, and emphysema. Mr. Elmendorf, I'm wondering what you think of a concept like that, and how trying to structure a payment program for some kind of health care reform could take advantage of prevention.
So, Congresswoman, if you propose a policy to enhance prevention for a single or a range of possible diseases, then we would certainly try to take account of the effects of that policy on the subsequent prevalence of those diseases and the cost of treating them in the estimates. I think there are a few general points to make. One is that as researchers have looked at a range of possible preventive measures, some seem to be very cost-effective and are not done enough. Others do not look particularly cost-effective, much like the range of results people see for different sorts of health treatments, in which some things are not done enough and others are done probably too much. So I think it depends, the effect on the future disease and the cost of that disease depends importantly on the particular preventive service or strategy you have in mind. And the related second point is that when one engages in preventive services, there are certainly some number of people who won't suffer a very health-damaging and costly problem later, but one is providing a lot of additional services to a very large number of people, many of whom would not have had that cost later. So part of the reason that preventive actions end up being less cost-saving than one might think is because one is providing them to a lot of people at a small cost per person, to be sure, but
right.
to a large number of people.
But some of them do, I mean, in line with what the President said yesterday, I think all of this should be based on science rather than our just our gut feeling. And so that would be part of what I would say, is you'd have to have some kind of longitudinal studies or some evidence that would show, in fact, that by giving a dividend to these prevention efforts, you would either A, improve people's health, or B, prevent longer-term disease. It's not just about preventing long-term diseases, it's also about improving quality of life.
Yes.
And Mr. Hackbarth, I see you nodding your head. I'm wondering if you can comment on this as well.
Yeah, I very much like the idea of it being science-based, because I agree with Mr. Elmendorf that you'll have cases where prevention can improve quality, but it may not reduce cost. And then you have cases where it will reduce cost a little bit, but not as much as the investment. So you need to have a very focused effort driven by science.
And you have to decide your criteria, because is your sole criterion saving money, or do you have the additional criteria of improving quality of life?
Right.
I completely agree. But would you think that would be an appropriate consideration, prevention, as we develop?
Oh, absolutely, guided by science, as you've described it.
Right. Thank you very much.
Thank you. Mr. Burgess.
Thank you, Mr. Chairman. Glenn, always good to see you, and glad you're back here in front of our committee. Seems like old times. Let me just concentrate on a few things that you listed in your list of where we can see savings. And I was really encouraged by the physician group practice demonstration project at CMS, and I hope that has not died a natural death with the change in helm. But really, that seemed to be, you look at the 20% of the people that account for 80% of the costs, and that really seemed to follow the old Willie Sutton's law: you rob the bank because that's where the money is, and that's where the money is in the Medicare system. I am concerned, and I think I heard both of you talk about increasing dollars to primary care physicians, a good thing, but anytime, since we're in a purely transactional environment, anytime we increase dollars to one, we're probably taking it from somewhere else. Is that a fair assumption, that this would be a redistribution across providers?
That has been MedPAC's recommendation, yes, that it be a budget-neutral change. And the reason that we've taken that approach is that, as you know, total expenditures on physician services have been growing quite rapidly. As that's been happening, there's also been a shift in the distribution of dollars away from primary care services towards more subspecialty services and imaging and the like. So there's been a shift that we think needs to be addressed in the name of enhancing our primary care system. We don't think the problem is too few dollars in the pool, just how they're distributed.
And along that line, and of course, we always hear that removing the cost of administered drugs and imaging would be some way to provide perhaps some more equanimity in that situation. Is that possible to do that into the current the current structure?
Are you talking about under the SGR and
Yeah.
how the SGR is calculated? We've not really looked at the issues, not taken a position on the issues of whether drugs ought to be included. We think that those are more issues of budget baselines than they are of health policy.
Let me ask you a question on, because you talked about readmission, and that is one of the things that makes me enthusiastic about the process, but also frightens me at the same time, because of some of the things I've seen us do in the past that tend to be heavy-handed. Now, under the physician group practice demonstration project, a patient is hospitalized for decompensation of congestive heart failure. If they're given, as they leave the hospital, the appointment time to see their primary care physician within 5 days, the risk of readmission really plummets. And if they are simply given the instructions to see their primary care doctor within 2 weeks, as opposed to actually having an appointment made, the readmission rate is significant, and those readmissions are terribly costly readmissions. So that seems to me to be a good thing. But if we simply say that we want you to take care of everything that might happen, or this is the way it may be interpreted by the hospitals and the physicians, we want you to take care of everything that might happen within the next 30 days because we're not going to pay you anymore. This hospitalization utilization is going to be it. Are we perhaps going to tend to drive utilization in a way that we hadn't intended?
Well, we too, like the physician group practice model, that's what we refer to as accountable care organizations. And the ideal approach is to have aggregations of clinicians and providers with a broad target, and then give them freedom to allocate resources in the name of both improving quality and reducing cost, just as you described it. The challenge that we face in Medicare is that not everybody is prepared for that format. Not all physicians are part of our large group practices or even involved in a hospital IPA type format is used in Connecticut in the demo. Right. And so we need tools to apply in situations where the group practice model doesn't fit.
Correct, and that's why, of course, it was important to do it as a demonstration project. And I understand from the 10 institutions that participated, there was probably one that was not actually institutionalized as an IPA. It was more of a group without walls and organized through the hospital structure.
Yeah.
But at the same time, these were groups that were then allowed, gain sharing is perhaps not the right word, but if they met a certain threshold, they certainly were rewarded for meeting that threshold.
Yeah.
And that incentive to drive behavior. You don't want to pay doctors not to see patients, because that's what we'll do. We'll not see patients. And then you get into the problem of his staff not being able to find a primary care doctor. That was the whole problem with the staff model HMO and a fully capitated environment. We don't work. We made all our money at the beginning of the month. Why struggle?
Yeah.
You close the doors and take the phone off the hook. That's the way to make money in that environment. And doctors are not stupid. We'll do that if that's what you pay us to do.
Yeah.
We have to be paid based on productivity as a general rule.
Yeah. So our goal, I think, aligns with yours, is to find ways to align physicians and hospitals and other providers to do the right thing, which is what they want to do, better quality at a lower cost. Our payment systems get in the way. So what we're trying to do is put some pressure on some places like readmissions, open some doors for people to go through with new opportunities like gain sharing and bundling of hospital with post-acute services, and say collaboratively, physicians, hospitals work together, reduce the cost, improve the quality, and share in the benefits with the Medicare program.
Well, I think the group practice model is on the right track, and I think sharing in that in the savings that occurs is on the right track. Bundling, we'll save bundling for another day, because I'm not sure I'm ready to go there yet. Doctors and hospitals, insurance companies do not trust each other at the present time. Thank you, Mr. Chairman.
The gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman. I'll begin with Director Elmendorf as well, and I'm going to try to follow up on Congresswoman DeGette's question. I was reading in Congress Daily today that there is a coalition of high-profile organizations on the Hill arguing that requiring offsets within a 10-year budget window does not look at the full picture, and it becomes a barrier to doing things that we're going to have to do if we're going to reform health care, as well as eliminate health care disparities. Because you don't see the benefits, you don't see the savings inside of that 10-year window necessarily. It takes a longer period of time. So what can we expect from CBO? Will this continue to be a barrier? Can we go outside of that 10-year window and budget for the savings that would be realized, both to fix the broken system that we have, to eliminate healthcare disparities, so that we won't be behind every industrialized nation and some developing ones for health status?
So, Congresswoman, CBO will continue to provide detailed estimates of the effects of health reform proposals over the 10-year window. We will try, where the evidence allows, to offer our qualitative judgment about the effects of certain reforms on spending beyond that. I understand your concern that there can be larger savings down the road that aren't captured. Unfortunately, we don't have the evidence or the modeling capacity to play out a whole set of specific reforms and how they are going to matter 10, 20, 30 years down the road. As I said in my remarks, many analysts agree on the general directions of policy, but there's much less consensus about whether the particular approach should be bundling, should be accountable care organizations, should be penalties for readmission rates, and a set of things like that. And that's the limits of the evidence as it currently exists.
Well, we look forward to continuing this conversation and seeing if we can find a way to address the costs that will have to be, and the money that will have to be invested to get to where we need to be. Mr. Hackbarth, we all know that Medicare plays a key role in our healthcare system, and there's several very strong aspects to the system, but there's still some areas that need work. We found that reimbursement rates within a city vary by zip code, for example. And we know that some of the proposed changes to Medicare, like those to Medicare Advantage and some of the ESRD reimbursement provisions, sometimes have a negative impact on subpopulations, largely African Americans and other communities of color. So as we make changes to programs, is MedCap taking this into consideration and looking for ways to reassure us or to ensure us that we are not inadvertently cutting access to needed services to some populations?
Yes, that's an area of increasing focus for us. For a number of years now, 3 or 4 years at least, we've been looking in particular at ESRD, the dialysis piece of the program, because that's so important to African Americans as well as others, and looking for any indication that changes in that system have impeded access for African Americans. In addition, we will be looking at the issue of access to kidney transplants, where there are some disparities in terms of access, and so this is going to be a focus of ours. We've also tried to look more broadly at differences in access to physicians and satisfaction with access to physicians.
Can I try to get
We've found some issues.
So you are looking at it. The bundling does bother me, and I believe as a physician and having been a medical director that information will change behavior. You're going to make the information public. Hospitals are not going to want to have a negative report given to the public. And I believe also that once hospitals are better reimbursed, which they would be when everyone is covered, they'll be able to provide the better services. So why a bundling pilot? It's going to put doctors and hospitals in competition, in ways that I just don't see why you think that would work.
Well, our goal is the opposite, not to put them in competition.
Or why it's needed.
But to put them in collaboration with one another. In the current system where they're paid separately, there is often competition, and as Dr. Burgess indicated, unfortunately, some places, some open conflict and hostility. We think that they need to be engaged, working together collaboratively to improve care, and we think bundling could be a step in that direction.
I agree, but I think that they need to work collaboratively. I just think there are other ways to do it. Thanks. Thank you.
Mr. Gingrey.
Mr. Chairman, thank you. Chairman Hackbarth, you had mentioned in your testimony, your written testimony on page 7, regarding payment system bias and the fact that many physicians who are subspecialists who do a lot of procedures are causing a problem in our manpower physician supply, particularly in regard to our primary care physicians. I know we have one sitting here in the audience from my state of Georgia, Dr. John Antalis, a former chairman of the president of the Medical Association of Georgia, who is a primary care physician. And I think about him. I think about my colleague, Donna Christensen, who is also a family doctor. Do you feel like this patient bias system may be a factor contributing to the various physician and nursing shortages we're seeing across the country? And what would you recommend that we do about that, possibly in regard to payment incentives?
Yeah. Well, first of all, I want to emphasize that physicians are responding to the system that we created, and the incentives that we create speak volumes about what kind of activities we value. And over a period of years, that means more subspecialization, more high-end imaging, and the like. So I'm not blaming them for what they're doing. They are responding to a system that we created. In the interest of a high-performance system, though, we need to redirect those signals that we're sending. And as I said earlier, we do think that payment deficiencies is one reason for the growing problems that we have in primary care. It's not the only reason by any stretch, but we think it is a very important reason, and so we need to get about changing that. And we've made a series of recommendations about how to change primary care payment.
Well, certainly, Chairman, that makes sense to me. And I, as a practicing physician for 26 years, as an OBGYN specialist, I concur that we need to do something about that to increase the number of primary care physicians and opportunities for medical homes, as we have talked about for all of our Medicare recipients. Director Elmendorf, let me shift to you for just a second. You talked about in your testimony in response to some of my colleagues' questions in regard to 10-year window, and that, you know, a lot of times you can't really measure or see the savings that are going to occur from various and sundry things that we have done. And it made me think about Medicare Advantage or Medicare Plus Choice, and the fact that we are on the verge, if we follow the president, well, indeed, in the economic stimulus package and what he plans for health care to create that reserve account so we can do all of this reform of health care, to take, I think it's $178 billion out of the hide of Medicare Advantage. Now, I don't know whether Medicare Advantage is working the way Congress originally intended for it to work, but certainly it was my understanding that the 10 million people that have signed up for Medicare Advantage are getting more than just episodic care. You know, they're not just going when their head hurts or their tummy hurts or whatever. They're getting a good annual physical. They're getting a call back from a nurse practitioner to make sure they're taking their medication. And clearly, that's going to cost a little bit more. Now, I'm not sure it's worth 15% more, and I know that's a concern of Congress, but it's worth more in that you're investing in something. And you're investing, I would think, that in the long run, in the final analysis, that at the end of life, let's say, we don't spend buku-oodles of money on those who have been under Medicare Advantage because they're healthier. They've taken care of themselves, and the doctors have taken care of them in a better way. We can't capture that, we can't score that dynamically, unfortunately. But I think at the end of their lives, when you look at it and compare the cost of fee-for-service versus something like Medicare Advantage, there may be a tremendous savings, and we're on the verge of gutting that. Would you like to respond to that in the few seconds that I've got left?
I think you're right that the patients in Medicare Advantage who are under the care of managed care organization who are receiving more integrated, more coordinated care than they might otherwise. Not all patients in Medicare Advantage are being seen by HMOs, though, for example. There have been patients who, under Medicare Advantage who are going through private fee-for-service plans, and Congress has taken action to reduce the number of people in that category. And that's the point that Mr. Hackbarth has made before about the importance of not just paying more for patients to receive essentially the same kind of care in Medicare Advantage. So some have been in that category. The others who are receiving this more integrated care, I think there are some advantages to that. I think most analysts, though, would be concerned about the point that you alluded to, which is that the reimbursement rates have risen relative to costs over time, and those patients are now receiving a variety of additional benefits that are of some value to them, but are costing taxpayers more per patient than would be the case in the traditional Medicare program.
Thank you, Mr. Chairman. Thanks for your patience and letting us go a little bit over. Thank you.
Thank you. Mr. Sarbanes.
Thank you, Mr. Chairman. Thank you all for being here. I wanted to pick up on this discussion of the primary care providers again, because to me, in many respects, that's sort of the elephant in the room. In other words, I've seen some statistics that say that if we were able to provide coverage for all those who don't currently have it, that in order to meet the demand that represents, we need another 60,000 primary care physicians. That's not even talking about nurses and other primary care professionals. So that's potentially a new train wreck that's coming. We talk a lot, and there's much of the debate and much of the focus is over the coverage side of this discussion. Is it going to be a hybrid, private, public? Is it going to be Medicare for all? Is it going to be single payer? Is it going to be employer-based, et cetera? But if we make the assumption for the moment that we will achieve universal coverage, then the question of who's going to provide that care becomes critical.
Yeah.
And there's a kind of a chicken and egg dimension to this. So if you could speak to that just a little bit more and maybe comment on the notion of having the design of the insurance be driven by the kind of providers that we're trying to bring, you know, if we build it, they will come kind of concept. Because I could make the argument that we should choose the insurance model based on
This is the second notice that the
which
factory warranty on your
providers-
vehicle may have expired and
know
should
what
be
that is.
reactivated to protect you against the cost of repairs. If you have not responded to this
I'm going to talk
notification,
through
it's
this,
not too
okay?
late. Please
We
don't make the
should-
mistake
we should
of
pick
driving
the
without a
insurance
warranty.
model
You are still eligible to
based
reactivate
on
warranty coverage. This is the
wanting to
final
get
call
more
before
primary
we
care
close the
providers
file.
in that. So
Press
what will
1 to speak
incentivize
with a
them
representative now
do that?
about your vehicle.
If you want to wait till that
Press 2
stops,
to be
you
removed
can.
from the follow-up list.
I'm sorry, I don't know exactly what's going
There we
on.
go.
Here we go.
Hold on. Does somebody have their phone on her?
Yeah,
I guess it's
I
over.
think it stopped, yeah.
All right, we'll continue.
Please.
On your first point, Mr. Sarbanes, that if we move towards universal coverage, we may increase the demands on an already weak primary care system. I think that may well be true. Dr. Gawande can maybe talk about Massachusetts, where anecdotally, at least I've heard that has become something of an issue. We think there are several responses appropriate within Medicare, and if you want, I can talk in detail about those. But in general, there are ways of increasing the payment for primary care, in changing the method of payment so that primary care practices can afford the infrastructure that allows them to provide appropriate coordination of care. Realistically, no matter what we do on the payment side, even if we did all of these things tomorrow, the increase in primary care physicians is going to occur slowly over a period of years. And that's going to be a real challenge for us. I think practically speaking, what we're going to have to do is expand our use of some non-physician clinicians, advanced practice nurses, for example, so that we can provide basic primary care to a broader population. I used to be the CEO of Harvard Vanguard Medical Associates in Boston, a very large group practice that made extensive use of advanced practice nurses to improve access to primary care. And I think as a national healthcare system, we're going to need to do more of that to deal with this issue as well.
I think, I mean, one way to approach this healthcare reform is to figure out what elements of everybody's proposal are in common, and then bet that that's where the final design will be in terms of critical components. And I haven't heard any proposal with regard to coverage or providers or anything else that doesn't include the notion that we need more focus on primary care. So because it's going to take so long to get the pipeline going, we probably need to bet now that that need's going to be there, regardless of what we design, and get going on it. And
Absolutely. There's a real urgency to move quickly on that front.
okay, thank you.
Thank you. Gentleman from Illinois, Mr. Shimkus.
Thank you, Mr. Chairman. I want to congratulate my colleague, Mr. Sarbanes, too. I think that was a great line of questioning, something I hadn't considered, so I thought it was good. I think if we adequately compensate, and then I would say protect physicians. I come from a big litigious state. Medical liability issues really drive people out. You know, my family practitioner who delivered my 3 boys no longer delivers babies because of medical, and we've talked about that, but in comprehensive reform, especially if the government takes a larger role in our community health clinics, there's liability protection there. I mean, the programs that are funded, and so that, I know some people aren't going to want to debate this, but it is a way to incentivize people to be in these professions, to give them some security. We still want people to get a redress for their grievances, especially if they're harmed, but that's got to be, I would think, and I didn't think about that till the line of questioning, so I do appreciate to that. I would also, in an opening statement, my colleague from California listed of things, well, why don't we do this, why don't we do that? I would ask the question, why do people from industrial nations that have national health care, why do they come here for catastrophic care? Or I would ask another question, why are all the major medical advances around the world, whether it's in devices or pharmaceuticals, why is that done here for the most part? There is something that's still going right in this country that's helpful to health and lifestyle and longevity that we just want to be careful that we don't disregard. To that point, I think that the thing that I fear most is a one-payer system. And the OMB Director Orzog talked about no one is talking about using cost information to deny needed care to beneficiaries, and that patients need to be protected from being denied what they need. This comparative effectiveness debate that we've now entered into raises, maybe not intentionally, but raises that concern that we're going to use cost. And I'll let you answer. I'll just tell you the story that I used. I was at a local university talking to nurse anesthetists, and I can say that. And it was a pretty big group, and we're talking about a competitive model versus a one-payer system. And they were asking me, and I'm readily up front, I'm highly biased in opposition to a one-payer government-run system, and I am a market-driven individual. And so I wasn't trying to deceive them. So I said, here's an example, and I talked about some of the industrialized nations having formularies, and if you don't fit that formula, you get denied care. And then I get a hand raised in the back of the room. I use New Zealand as an example. And the lady stood up and she says, I'm from New Zealand. And I thought, I'm either right or I'm busted, man. I'm busted. And she told me that her father had to wait for kidney stone surgery for 8 months. Now, for those of you who had kidney stones, knows that that was a terribly long wait. I guess my question would be, do you share these concerns as we move in this direction on a debate on national policy? Go ahead, Mr. Hackbarth.
So, Congressman, I think many analysts worry that our current system provides no reason for many providers and patients to think about whether extra treatments are cost-effective or not. It's also quite fair to worry, as you do, that we could devise a national health system in which cost would become the predominant criterion for what is provided and not. And that's why I think many analysts suggest moving in the direction of learning what works and providing incentives to take that knowledge seriously. But I think few analysts suggest that we should move to a system where one person in Washington decides who gets what. And one thing we will discover in future comparative effectiveness research, as has been discovered in past research of this sort, is that some procedures are very good for some patients and not very helpful for others.
Can I follow up? And I don't want to cut you off, but I'm going to ask this for the second panel. Defensive medicine in liability protection, will that be part of the cost effectiveness analysis?
I think the consensus of researchers is that defensive medicine is a factor, but not a particularly large factor in the decisions of providers and patients.
But do you think we'll see that in this cost effectiveness analysis? Will that be considered? I mean, we won't know until we get the stats. And if this is an issue of trying to figure out the cost, you would think that that would be part of the variables.
So I think the most direct connection is that currently, if one is facing a patient with a particular problem and there's very little evidence about what to do, then there can be a reason for the provider to do the most that can be done, and that can be expensive. Whereas if there were clear evidence on what worked and what didn't, that would help providers avoid having to prescribe everything to protect themselves. So in that sense, I think having the knowledge can reduce the amount of defensive medicine that is practiced, apart from the liability issues that you've raised as well.
Thank you.
Chairman's going to let me.
You wanted Mr. Hackbarth to answer the same
Yes,
question?
and I'll
Sure.
shut up.
Yeah, I was going to pick up where Mr. Elmendorf left off. Ideally, what we do is develop scientifically based, evidence-based standards of practice based on the best available evidence. It seems to me that if you have that information, then it can provide some comfort and protection to physicians that practice in accordance with that guideline, that standard of practice. When we're information starved, as we are so often now, the response is, well, do more. More is synonymous with better because we don't have sufficient evidence to show otherwise. So that's the refuge. We need to create another refuge, if you will, so more isn't always the response to uncertainty.
Thank you. Ms. Schakowsky.
Thank you, Mr. Chairman. You know, we just heard an anecdotal story about somebody who had to wait for kidney stones, which my husband having had them, that certainly is a problem. But you know what? There's also millions of people, insured as well as uninsured, who wait a lifetime for the care that they need in this country, because we do ration health care, and by and large, that ration card is a dollar bill. And you can shake your head, but
If the general lady will deal, everyone who needs care gets it, because when they go into the emergency room, the hospital has to
The
serve
gentlewoman, I assume, has
I
yielded to
I'm
the
going to
gentleman.
take back my, no, I'm going to take back my time, because the myth that everyone in this country receives the care they need has got to be dismissed, because that is not true. Over half of Americans, I said in my opening statement, the data shows, actually have gone without or postponed health care because they can't afford it. That is just a scientific fact. We have looked at the American people, and that's just true. But here are my questions. First of all, I wanted to ask Mr. Hackbarth. You talked about the percent of readmissions in hospital. What was that percentage?
About 18% of each Medicare admissions are followed by a readmission within 30 days.
Okay, I just wanted to have that. But I wanted to get back to this model. You know, we do have a single-payer health care system in Medicare right now for elderly people. And again, I had said before that this is a widely accepted and much liked, and it still has holes in it. And I wanted to ask about one of those holes. We've heard Medicare Part D lauded as something that has worked so well. But certainly in my office, we get people all the time confused over those many, many options. Senator Durbin and I and others in the House have introduced legislation that would create a public pharmaceutical option under Medicare. I wanted to get comments from both of you on whether or not, and that option would be able to negotiate with Medicare with the pharmaceutical companies for lower prices, hopefully to fill the donut hole. I wanted to get your opinion on that.
So referring to drugs specifically, CBO's judgment is that the private providers of the drug benefit do negotiate for low prices. They negotiate with the threat of moving drugs off of their formularies or charging higher prices for their use, and that there's no reason to expect that a public program would do better unless it were prepared to be tougher in not covering certain drugs. And if it were tougher in writing its formulary, then it could avoid, then it might negotiate for lower benefits. But that would be the crucial, lower drug cost, that would be the crucial factor. More generally in healthcare reform, when people talk about public plans competing with private plans, I think designing a system in which a public plan could compete on a level playing field is extremely difficult. It raises issues of what the providers are paid. It also raises the issue of selection of patients across plans and how sick they are. It's issues about how the financial risk is dealt with.
You're saying whether a public plan could compete with a private plan, who would be disadvantaged? Which would be disadvantaged?
I'm saying that if the objective is to have them compete on a level playing field, it's very
I know. Who would be
difficult.
disadvantaged? For whom would it not be level?
Well, under current payment rates, then a public plan would be less expensive because than the private plan, reasoning from the Medicare example, where the government does push down reimbursement rates. That would be a benefit for the public plan. The other issue is it depends just how you design the system. So there are risks associated with running health plans. If the public plan didn't have to insure itself against that risk, if it was just the taxpayers holding the bag, then that would be an advantage for a public plan relative to private plans that have to charge enough to cover that risk. It depends how it's designed. If public plans ended up with sicker patients than private plans because perhaps they managed benefits less tightly, that would be a disadvantage to public plans relative to private plans. So it's a set of parameters that you and your colleagues will pick that would affect whether one plan is advantage, whether a public plan is advantage.
Does it matter that the CEO of Cigna in 2007, for example, made $22.7 million, a cool $23 million, about more than the President of the United States in a year, and the kinds of overhead costs that private plans have as opposed to Medicare, for example? I mean,
yeah, so administrative costs are including the costs of paying executives are another factor that I forgot to mention. Medicare does have lower administrative costs.
For profits
and
for
even large
shareholders.
Employer returns. That's right. But remember, the profits for shareholders, part of that covers the risks that I've just discussed. It covers the cost of the capital that goes into managing these plans. So some of that's why I said it depends importantly
well, how is it, my time's running, how is it that the United States of America pays 40% more than the closest country for health care, causing the President of the United States to say, I think in response to something that Mr. Pallone said, are you saying that there's not enough money in the system currently to cover everyone? Are you saying there's not enough money in the system right now to cover everyone?
Oh, no, I didn't say anything like that. What I said in my testimony, and that is the position of CBO, is that covering everyone would be expensive, that there was also a lot of dollars spent in the healthcare system for which we're getting a little or no improvement in health, but that rooting out those dollars without also reducing some services that do improve health is challenging. And we've talked, and I think most people agree about the importance of information, the importance of incentives to use that information. But exactly how to do that, and how to do that in the short run, is not so clear. again, the direction is clear, but how effective that can be, whether that can save enough money to cover the increase in health care that would be delivered to the currently uninsured, is much more difficult.
Well, okay.
No, that's all right. I'm just going to, take a 30 seconds here as the chairman. What the president actually said in response to my question at the summit, and I think it, hasn't been laid out here, is that, you can have a lot of cost efficiencies, and that can contribute to expanding coverage. But he said that you do need a lot of money up front. In other words, those savings may, occur as the reforms kick into place. But initially, you're going to need a new source of revenue up front, because a lot of the things that we're talking about have large costs up front, and then the savings come later. So, that's one aspect of this, that we have to think about. But I want to thank the gentlewoman. Mr. Rogers.
Thank you, Mr. Chairman. Thank you both for being here today. You've said some things that make me scratch my head a little bit, and I think we're kind of dancing around some pretty important issues here, because we don't want to use the words that we know inflame the fears of most Americans, and that's rationing. And I have to tell you that as a Michigander, we can see directly the impact of a government-controlled system for health care in Canada. And as one Canadian told me, that if you break your leg in Canada, you have the best health care ever. If you get sick, it's the worst in the world. And I think what they're talking about is sustaining that system of health care is very difficult. And I find it interesting that there's a great number of our surgeons who do cash business with Canadians on weekends for hips and knees, because the system in Canada just rations care for elderly, and elderly starting in the 60s. And you said, Mr. Elmendorf, a couple of things that I found interesting. You talked about in this government-run plan that they would hunt for bargains and do those kind of things, and you said in order to work they would limit what coverage they had, and then later in answering questions you said in order for this to work there had to be some limitation for maximum effect on costs. And then I want to go back to something you said in your testimony. You were talking about the comparative effectiveness language would ultimately have to change the behavior of doctors and patients. And if they're basing that on information available and a doctor's decision between a doctor and a patient, I'm for it. That's a great idea. But later you say bringing about those changes would probably require action by public and private insurers to incorporate the results in their coverage and payment policies. You are quite clearly advocating for rationing care through what is covered. And here's my concern. 85% of Americans have coverage. We often talk about the 15%. And it seems odd to me that we're going to say because we have this 15% that we should figure out a way to get access to health care, we're going to start rationing care for the other 85% who enjoy some pretty good health care in the United States. And maybe you can help me untwine that in both your oral comments and your written testimony.
So first, let me be clear. I'm not advocating for anything. The CBO does not make policy recommendations. So nothing in the testimony or in my answers to questions says that Congress should proceed certain ways on policies. What the testimony does say, and which I stand by, is that more information by itself is not going to have as large an effect on just providing the information, will not have as large an effect on practice patterns and on costs as creating incentives for providers and patients to make use of that information. And I think that's consistent in what's written here and the answers I've given to questions.
Okay, but it says you require action to incorporate the results in coverage. And so when you say incentives, are you saying they should build that into the coverage, meaning they should restrict certain?
I'm not saying they should. I'm saying is that the rising costs of health care, which are linked to the increasing utilization of expensive services, that rate of increase is would be changed more if private insurers or public insurance plans created incentives for providers to take account of information about what was and was not most effective. And some of that information they will take account of anyway, but not as much as if there are financial incentives.
Okay, and just, I still think we're talking around it, but say that you're not advocating, even though I would say probably require, certainly sends a pretty clear message where you're going there. But in the other countries, and we've seen it in the UK, breast cancer, kidney cancer, Alzheimer's, and hip and knee replacements happen to be a big one. I think in the UK they just had one as young as 62 was denied care and coverage for a knee replacement. How do we avoid that? I mean, I think if we are going to be honest with Americans, we have to tell them, hey, this is what's coming. Because the only way we can fix the 15% problem is we're going to take it away from the 85% who have coverage. I just think we're smarter, better, more innovative than that, and I think there's a way to do that. But how do you stop that from happening, given your testimony today?
So let me just be clear one more time. The testimony says to reduce health spending, results of comparative effectiveness would have to be used in certain ways. Bringing about these changes would probably require. Again, it's not a statement of CBO's preferences. It's the chain of logic of what would be required to affect the path of health spending. I think the crucial point that many of us have made here today is that a large share of U.S. health spending does not seem to be improving health. You can look at and one particular piece of evidence for this is the geographic variation in spending under Medicare that does not appear to be correlated with the quality of care as judged by the measures that are available. That holds open the possibility, I think the very important possibility, that more evidence of what works and incentives to use it could squeeze out that money. It's a lot of money. By some estimates, $700 billion a year. As I noted before, doing that without affecting care that does improve health is not an easy task to accomplish, even if analysts generally agree on some of the plausible directions. So I think that holds open the possibility that we can reduce care that is not very useful and save a lot of money through doing that.
And then I understand. I think your words sometimes we're kind of parsing around what you're trying to say, and you're trying to say in order for it to work, you have to limit coverage in the future under government-run plans. I get it. Matter of fact, you also said that under a government plan, they would push down reimbursement. Well, if you've ever had a meeting with a medical provider in the last month and a half, and I'm sure you have, they can't get the reimbursement they need today. And it's having this inverse impact on private insurance companies trying to be asked to hold the burden of the government-run plan that pushes it down. So you're going to destroy competition in the market. I don't know how you think that works. And I don't know about my colleagues. We're getting calls in my office. People are in a panic because in cancer care reimbursement, where I think that you all have completely missed the boat, they're calling and saying they're not taking any new patients under Medicare because the reimbursement rates are wrong and they lose money. So to start out the premise that the government is going to push down reimbursement rates as a way to control costs and somehow a private plan is going to survive, it defies the logic of what's going to work in the marketplace. I don't know how do you reconcile that?
Again, I'm not advocating pushing down reimbursement rates. What I'm saying is that under the current Medicare system, Medicare pays less to providers than private payers pay. A number of options that we've considered, a number that MedPAC has recommended, in fact, but we don't make recommendations. A number of those options that have been discussed would reduce payment rates. In fact, under current law, as you know, physician payment rates under Medicare will drop very, very sharply this year. The evidence suggests that the shifting of costs to the private sector is not as acute as one might worry, that in fact the private insurance companies negotiate using with the providers and achieve the rates of reimbursement that they can. To the extent that Medicare and even more so Medicaid pays less to doctors and to hospitals, that is taken out mostly in some combination of reduced quality or reduced amenities for those hospitals and doctors. Not clear how much of that, though, as I said, spills over to the private sector.
Yeah, I appreciate it. And just as a follow-up to Mr. Hackbarth, if we had had a government-run prescription plan under Part D, what would that have done to the competitive plans in Part D, in your estimation?
Well, MedPAC's never looked at that issue specifically. Of course, we have spent a lot of time looking at Medicare Advantage, which is a system where we have a public plan and private plans competing with one another. And there, far from the playing field being tilted in favor of the public plan, it's been tilted significantly in favor of the private plans. So in the one real-world experience we have with this idea, the fears that, well, the public plan gets favorable treatment has, in fact, not been the case. Having said that, I am a strong believer that we need both strong public plans and private plans in our healthcare system. I've worked in both. I worked in what was then HCFA, obviously deeply involved in Medicare issues now. In my prior lives, I've worked at premier HMOs, so I understand a bit about both. I think they bring distinctive strengths, different strengths, complementary strengths. On the one hand, Medicare as a public plan, as noted earlier, has low administrative costs, in part because of scale, in part because it doesn't incur marketing expense and in profit, as discussed earlier. In addition to that, because of its size, it's able to command low prices. On the other hand, private plans have some advantages as well. They are more flexible than a government plan can ever be. It's easier for a private plan to change how it pays providers to better reward the sort of behavior that we've been talking about today. It's a cumbersome process for Medicare to make those changes. It involves legislation and regulation writing in CMS and the like. So private plans have more flexibility there. In addition, private plans have the opportunity to try to identify a select group of particularly efficient, high-quality providers and direct patients to them, which is not feasible in a public program like Medicare. So you have two types of health plans potentially competing with one another, offering different things to Medicare beneficiaries. Some will like the public plan for what it offers, the free choice of provider and the like. Others might like Kaiser Permanente as an alternative. Rather than saying, well, we want one or the other, I think we ought to be striving to build a system that has both strong public plans and private plans competing on a level playing field.
Thank you. Ms. Baldwin?
Thank you, Mr. Chairman. One quick comment before I get to my questions. I know we've had a little bit of discussion about public plans versus private plans in the playing field, and even in the Medicare Part D context. I would draw attention to the fact that I think Wisconsin is the only state that does have a public plan in the Medicare Part D program called Senior Care. It was based on a pharmacy waiver that was granted prior to enactment of the Medicare Part D program. It is wildly popular to the degree that on a bipartisan basis, every member of the Wisconsin delegation weighed in to try to keep that program in existence as the Medicare Part D program was phased in. And I think it would provide an interesting analysis for some of the, to see whether some of the comments we've been hearing are really have a basis or not. To my questions, Chairman Hackbarth, I wanted to explore with you and have you talk a little bit about the value of demonstration projects as a way to go from current payment systems to perhaps testing some of the recommendations that MedPAC has made for reform. Congress, it seems, has funded through Medicare legislation for years demonstration projects such as the physician group practice demonstration or the premier hospital demonstration. Yet it seems like we fund those projects and don't insist that they're replicated elsewhere or expanded on a much more broad scale. I'm curious about their value to inspire confidence that new models of payment will achieve desired results, and whether we ought to be looking at more. Please comment.
I worry about this a lot and more over time, and I think it's an issue that MedPAC is going to try to think through more systematically. But let me offer some personal thoughts. We've got to make a lot of payment changes for all the reasons that have been discussed today. The changes that we need to make are sometimes operationally complex and uncertain in terms of their effect on cost and quality. And so it stands to reason that we may want to do tests of them first. The fear that I have about the process that we've been using is that often the tests are small, and so our ability to detect meaningful results is compromised. There are small projects that run for a few years, and we're trying sometimes to affect things that will only materialize over a longer period of time. There's almost a bias in the design toward finding no effect. And then we throw out the idea and say, well, that didn't work, and we'll go on to something else, when in fact it may be in part a function of the limits of the design. A second issue is that even when things work, and I think you were pointing in this direction, then they've got to come back through the legislative process for further consideration and maybe modification in ways that might undermine whatever success we found in the demonstration. And so it seems to me that Congress may want to consider ways that we can accelerate that process, do more of what we've referred to as pilots, large-scale tests that will be better able to find whether it works or not. And if it works, according to pre-established standards, move immediately towards implementation as opposed to saying, well, let's now go back through the legislative process again. So those are a couple ideas, but I think we need to look at the whole process of innovation and payment and figure out where we can take out unnecessary steps and unnecessary resources and streamline that process. We've got to get better way faster than we are right now.
You and I have had a chance to talk about this sort of pilot idea before. You would conceive of that under the auspices of CMS, and are there good examples of that working in the past, or is this something that we would need to authorize?
Well, the most recent example was in the disease management pilot. It was retitled, I think, Medicare Health Support or something like that. And the intervention that was being tested was having third-party disease management entities counsel patients, provide information, make sure they take their meds and whatnot. In that case, the intervention was pretty large scale. The test was pretty large scale, and the finding was no effect. But the legislation had authorized the department to go ahead and implement program-wide if it had worked. And they found that it didn't, so we didn't go down that path. We need to do more of that. I think that's a model worth maybe tweaking some, but exploring for future projects. And bundling is an example that we have suggested a pilot approach.
Thank you.
The gentlewoman from California, Ms. Capps.
Thank you, Mr. Chairman, and thank you both. I read your statements. I wasn't able to be here, but I have a question for each of you, and I know I have 5 minutes, so we can base it accordingly. Both of you discussed the fact that we lack primary care coordination of and incentives for primary and preventive care. Mr. Elmendorf, you mentioned in your testimony that the potential effects of initiatives where we might invest more now, which preventive care is all about, and not realize the savings until later. This would be certainly true in efforts to offer preventive care services, but right now the CBO doesn't even allow us to account for savings. And as I've often said about a field that I care a great deal about, which is preventive health care as a public health nurse, there's no special interest group pushing for preventive health care. And so my question is, how do we integrate into our proposals a way to realize that the savings later are what we're investing now for? And if you could give me your response to that. I have a different question for you, Mr. Hackbarth.
So, Congresswoman, CBO does not just as a blanket matter ignore the health effects of changes in policy. The tobacco example was raised earlier as a case where we very specifically look at the effects of higher tobacco taxes or tougher tobacco regulation and try to trace that through to the effects on spending, for example, in Medicaid, the number of premature infants that are born and the costs of that. We are very actively looking for evidence to help us trace through the effects of changes in policies on health and then on federal and on private health spending later. So in no sense are we putting those issues to the side. We are focused on them. The problems that I mentioned are lack of evidence in many cases,
right,
or very long-run effects in many cases, and it's just more difficult to trace things out over several decades.
When you talk about tobacco smoking, it's a specific act, and when you talk about prematurity, there's a specific entity surrounding. I guess what I'm talking about in the area of prevention, some harder measures that are maybe more pervasive. Comprehensive health education for kids in a school curriculum, some subject dear to my heart. Most school curricula have no place for it today. And if we were to target things like that, maybe not that specifically, where it's general education, but targeted toward preventive health care, are you looking to us or to some academic or some study group to measure the impact of the input and then some kind of impact and outcome?
Yes, so we look to outside researchers to guide us in the choices that we make in our estimating process. So on the tobacco front, there's been a wide range of research about the effects of tobacco.
How about obesity
on health
and
outcomes.
diet and exercise?
And I think that as well. I think on obesity, there are several steps of the prevention that have to work. So I think there is a good deal of evidence about the effects of obesity on health problems, less on how particular public policy changes will
So
affect
that's what we
obesity.
need to work on.
And that's when we look for
And
all
I
the
hope there are
evidence
some
in the world.
outside researchers listening who will help us take the ball. I want to turn to another topic, but that's one that certainly needs to be explored further, and I appreciate what you've just said. Mr. Hackbarth, in your testimony, you alluded to the declining number of medical students pursuing a career in primary care. This has been well demonstrated. Could you please expand on how you drew the correlation between Medicare reimbursement structure and this decline? And if I could just roll all my questions together, you'll understand. Could you offer some suggestions on how we would need to restructure a payment system to incentivize primary care, and how this would then spill over to private payers, if that's not too much for one?
So in the first question, the relationship between payment levels and the decline in interest in primary care, I'm not going to be able to point to particular studies off the top of my head, but we could...
Maybe you could get back to us if you know of some.
But certainly in talking to people involved in medical education, including some of our commissioners and other people that I work with in other walks, what I hear from them over and over again is that medical students considering their career options often point to a couple things about primary care that make it unattractive. One is the income level relative to other specialties. Second is the demands, the lifestyle demands that they experience in primary care as opposed to some of the other specialties.
Could I interrupt by just asking, do you think the cost of medical school has anything to do with that? I'm seeing a lot of people nod behind you.
Yeah, it certainly could. Obviously, if you're making a salary or an income that's 2 or 3 times larger, you can pay off those medical school loans a lot faster. And so the cost of medical education is not equal for all specialties, but it tends to be a real problem for people considering primary care. As far as what to change, we've made 3 types of recommendations. One, you're familiar with the process of establishing the fee levels, the relative value scale, and we've identified what we think are some problems with how that process works. In particular, we think the process focuses more on things that are undervalued and increasing values than things that are overvalued that need to be reduced. The net effect of that bias that we've seen in the system is to hurt primary care
Exactly.
fees. And some steps are being taken to reform that process that we're cautiously optimistic about. The second thing that we've recommended is what we refer to as a primary care modifier. It's basically a bonus for physicians and other clinicians who, through their practice, demonstrate that they're committed to primary care. So it would be a modifier. You would get your fee plus an increase of 5 or 10% if you are designated as a primary care clinician. The third thing that we've recommended is a large-scale pilot of the medical home idea, a key element of which is to say for primary care, because of the unique nature of the specialty, we ought to pay not just fee for service, but on top of that pay a lump sum per patient to cover activities that are not included in the Medicare fee schedule, various counseling activities, following up on specialty referrals and the like, plus give primary care practices money to build some infrastructure, including hiring staff that would allow them to more effectively coordinate care, especially for complex patients.
Is that proposal? I'm so sorry. Oh, I know. I'd like to follow up on that topic with you, too.
Happy to talk more about it.
Thank you. The gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman. Mr. Hackbarth, I understand you may have touched on this already, but I'd just like to expand it a little bit. In your testimony, you mentioned that one way to cut costs for Medicare is to reduce payments for hospitals with relatively high readmission rates for select conditions. You go on to say that we know that some readmissions are avoidable and, in fact, are a sign of poor care or missed opportunity to better coordinate care. The premise being, of course, that keeping readmission rates down is critical not only for saving costs, but for quality care. I'm interested, though, in what criteria would be used to deem a readmission as unnecessary or avoidable. I mean, how do we know that we're only penalizing hospitals for readmissions that could have been avoided?
Yeah. Let me just begin with a little bit of factual background. Okay. If you look at the rate of readmissions within 30 days varies according to the type of admission it is. So it's the rate is higher for some things than others. Take a condition like congestive heart failure or chronic obstructive pulmonary disease, very common reasons for admission among the Medicare population. You see as much as a 4-fold difference between in the readmission rates between the hospitals that are the best and those that are lagging. So we're not talking about small differences here. There are quite large differences. Our approach would be to look at the readmission rate and set a threshold. And obviously, it's policy judgment about how high to set that threshold. But you could set it at quite a high level so that you're basically hitting institutions that are way, way above the mean, way above the average in terms of their performance on this dimension. And we believe that with appropriate incentives, and it could be structured different ways, that by focusing people's attention on it, we can improve performance. And there are models that they can look to. There are institutions, Don Berwick's organization, the Institute for Healthcare Improvement has really started to focus on teaching hospitals the things that they can do to reduce their readmission rates. So you want an incentive coupled with support, information on how to improve.
Again, and this is an example in a way of those preventative measures we can take to reduce costs. What we don't want to do is, though, have an incentive that goes too far the other way and people who need to be readmitted aren't readmitted. So that's the balance there. Mr. Elmendorf, I understand that in keeping with CBO's nonpartisan role, you can't offer recommendations on any specific policy options. But do you think if we fail to enact some meaningful health care legislation in this Congress, that the cost to tackle reform down the road will be greater? And if so, in what specific areas do you foresee the highest increase of costs?
Congresswoman, I appreciate your understanding of the role of the CBO in this regard. Many analysts would agree that the changes in the health care delivery system that would be needed to improve the efficiency of delivering care will be changes that cannot be made overnight. As I said in my testimony, there are decades of experience following the rules as they've been laid down, the structure that the policies have been created, and a lot of ingrained habits, and devising the right sorts of incentives, collecting the right sorts of information, and then letting the healthcare professionals make the improvements in what they do is a task that will take time. So the sooner this process is started, the more unnecessary and ineffective care can be avoided. The longer that policymakers wait to create the incentives and help to provide the information, the more unnecessary and ineffective care will be given. And because the rising cost of health care imposes such a burden on the federal government and on the private sector, the more it will be necessary to make starker, more radical changes to balance budgets to let employers and families pay for health care down the road. And starting sooner is a way to make the changes most based on evidence and the most effective way.
Thank you.
Thank you. Mr. Murphy.
Thank you very much, Mr. Chairman. It's curious to me, listening to people talk on this panel and in other forums, about how we talk about this issue of rationing, as if rationing is some futuristic, catastrophic development that's going to happen in our healthcare system, when we know it happens every day, right now. Medicare makes decisions on who gets care and who doesn't. This Congress makes those decisions. And in particular, private insurers make those decisions, sometimes based on medicine, but other times based on cost. And so I wanted to bring one particular difference that I see between private plan management and public plan management to your attention and get your thoughts on it. When I was chair of the Health Committee in the Connecticut State Legislature, we brought in our insurers one afternoon to talk about a development that occurred in that the insurers had essentially stopped covering bariatric surgery across the board. Now, certainly there are a lot of abuses in bariatric surgery where it's more cosmetic than medical, but we know that there are plenty of circumstances in which it saves lives and reduces enormous costs later on in the system. The answer that we got from the insurers, not necessarily when they were all sitting together, but privately, was that because the average time that an individual spends on their particular plan is only 2 or 3 years before they switch to another plan, that it didn't make sense for them to pay for that enormously expensive surgery up front if they weren't going to bear the benefits of the person's extended health down the road. And it seems to me to be a particular handicap of a private insurance system and where people now, even if they stay with an employer or move from employer to employer, are moving from plan to plan over a long period of time. It's a perfect example of the tragedy of the commons. If they all made the decision to cover bariatric surgery, they would all be benefited, but they don't because they are calculating that they are going to pay the cost and not receive the benefits. And so in evaluating whether the question to you, Mr. Hackbarth, is how do you look at that particular problem as you weigh the benefits of public or private plans, and then to Mr. Elmendorf in terms of looking at how you score a new system that's reliant on the existing system of private plan management or an expanded public option. Is that an issue that gets considered in your cost estimates?
Mm-hmm. A couple thoughts. Earlier, I was talking about public plans and private plans each have distinct advantages. And if you're a private plan and you're in a market where there's lots of turnover in your enrollee population, it would be surprising if they didn't make the sort of calculation that you were talking about. I'm not going to have this patient in the long run, and that could influence their thinking. I don't think that's true of all private plans, however. There are some, like Kaiser Permanente, who take the long-term view, in part because they have pretty good stability in their membership, but in part also because it's the right thing to do. So I wouldn't want to cast all private plans in the light of being, calculating green eye shade types that are just looking for short-term profit. Some are that way, others are not. The last comment I'd offer on this whole subject of rationing is that, it's been characterized, well, the haves and the have-nots. That's an important dimension of the debate, but let's just focus on the haves for a second. I think we're all of two minds about the soaring cost of health care. If we are the patient or our loved one is the patient, of course, it's only natural that, we want access to the latest, most innovative treatment that can help them get better. On the other hand, we're also all taxpayers and premium payers. Mr. Elmendorf can correct me if I'm wrong, but I think this most recent economic expansion was pretty unusual in that the median income did not rise. And a big part of that was health care was taking the money out of people's pockets. And there are a lot of Americans who are very worried about that, in addition to the possibility of losing their health insurance altogether. So, I don't think this is haves versus have-nots. We've got finite resources as a society. We need to figure out how to use them most effectively to achieve all the things we want to achieve.
To the extent that a public plan would provide more services now that would save costs down the road, that's something we would certainly try to incorporate in our estimates. As I've said a couple of times, it's very difficult to track all of those effects, but certainly something we would try to have in mind. The only thing I would just add is that incentives can be created for private plans that would not otherwise do the sorts of preventive services that are important to do them. The government could pay for vaccinations, flu shots, things of that sort, administered through private plans or through public plan. So there are ways to work through the private plans to accomplish some of those objectives as well.
Thank you. I think that concludes our questions. So I want to thank you very much. First of all, you raised some major new ways of doing things and looking at things and all the cost efficiencies. And, it's very helpful in terms of our trying to craft healthcare reform. So thank you very much. Thank you.
Thank you, Mr. Chairman.
And I'll ask the next panel to come forward.